We're grateful that you took time out of your day to learn from some of the leading oncologists in the field of lung cancer. We are so grateful to the faculty who have given their time on a Saturday to share their knowledge with you. We're also appreciative to the sponsors of our event: AstraZeneca, Lilly, Novartis, Takeda, Boehringer Ingelheim, Blueprint Medicines, and Genentech. All right, with that intro in mind, I'm going to segue to a brief intro on what we're doing today. There are three basic types of treatments that we use against cancer. First is surgery. Surgery is, I think, very familiar to everyone. It is the physical removal of a tumor. Surgery has two very distinct advantages. The first is that whatever is removed is outside of the patient that we care about. And the second is that we can study it. You can look at it under a microscope. You can do all kinds of advanced molecular testing, a lot of which we'll talk about today. The next is radiotherapy. Radiotherapy's great strength is that it works quite nicely in lung cancer where you shine the beam. Its big disadvantage is it works nowhere else. And finally, medicines. We use medicines to attack cancer. Now, medicine's strength and weakness are really the same, which is that they get everywhere. The good side of this is that it at least tries to attack cancer in every location. The downside, of course, are its side effects. Within the classes of medicines used to attack cancer, there are three very basic types. The most famous, perhaps the most infamous, are chemotherapy, or as a doctor might call it, cytotoxic chemotherapy. These are poisons, but they're poisons with a very specific mechanism, which is to say that they kill dividing cells by mucking with their DNA. And this is an important concept because most of the healthy cells in the body don't divide. They sit put and they do their job. In contrast, cancer cells are dividing all the time. That's how they grow and cause the evils that are cancer. And so they are particularly susceptible to this poison. Of course, there are cells in the body that are susceptible to the chemotherapeutic poison, thus the side effects that I think we all know very well. The second class is immunotherapy. Immunotherapy are drugs that use the body's own immune system to attack cancer. This is a very important and very exciting new class of medicines that nonetheless isn't so much our focus today. Our dominant focus today is on targeted therapy. And I want to discuss what targeted therapy is. I want to start by just making sure we're all on the same page about what cancer is. Human body, like all living things, is composed of microscopic building blocks called cells. Cells are tiny. The size of the tip of my pen is the size of about 10 billion of them, be they healthy or cancerous. Inside of each of these cells is an area called the nucleus. And in the nucleus is the DNA. DNA are the instructions of the cell, the blueprint of the cell, if you will. We get different types of cancers for two basic reasons. Number one, there are many different kinds of cells in the healthy body. And number two, those cells can get different kinds of mutations to make them go bad. So if there are two basic types of lung cancer, these are small cell, and since our pathologists aren't terribly creative in their naming, the much more common non-small cell. Within non-small cell, one subtype is called squamous cell carcinoma, and the other, again, our pathologists aren't terribly creative, is non-squamous. You may have heard the term adenocarcinoma. Most non-squamous, non-small cell lung cancer is adenocarcinoma, and we'll use those pretty synonymously today. So if you hear non-squamous or you hear adenocarcinoma, they're basically the same. And what for the most part we're talking about are glandular cells. So in the lung, cells whose job is to secrete mucus into the lung. When one of these cells gets these mutations or mistakes, it forgets how to do its job. It learns how to make copies of itself, spread and grow. Now, why are we diving so deeply into this biology? Beyond that, many of us, probably all of us lecturing today are molecular biology nerds. But beyond that joke, which in a virtual forum, I have no ability to know if that hit or not, we care because there are therapy options we can use to help patients. So we're talking about mutations. So if cancer is a disease of mutations, it takes many of these mutations to make a cancer. When we talk about targetable mutations or driver mutations, we're talking about an event that happened very early in the conversion of a once healthy, useful body cell into a cancer cell. As a consequence, the cell really, to be a cancer cell, really needs it. And so if we muck with the signaling coming from that, it can be very, very effective against cancer. And that brings us, of course, to the heart of why we care, that there are certain themes that emerge when you have targeted therapy. So we're talking about matching, like a lock and a key model, matching a target with a targeted therapy or a mutation with a cancer pill. And as a theme, when you match these correctly, you get treatment that is more effective. So it knocks the cancer down harder. It's less toxic than chemo, so it knocks the patient down less. And of course, it demedicalizes the life of the patients because they're pills instead of IV. And of course, also because there are fewer side effects, less suffering from the treatment, and because it knocks cancer down more effectively, less suffering from the cancer, right? So less time in my office and more time with the grandchildren or whatever important to the patient at hand. Most of these patients happen in these mutations happen in these non-squamous or adenocarcinoma patients. Another important point here is that at least with the older classical mutations that we've known about for longer, they're statistically more likely to happen in patients who've never smoked or have a more limited smoking history. But in the modern era, there's really no role for clinical phenotyping. The appropriate standard is to just sequence everybody's tumor, at least everybody with non-squamous disease, and then treat by the molecular phenotype, not by any other characteristics. Historically, and until very recently, these have been treatments aimed only at stage 4 or metastatic or incurable cancer. But you're going to hear about data today about the evolution of bringing these wonderful therapies perhaps into more local stages. It remains very controversial, and we'll try to share with you what is known.